you, David, yourself. But I'm seeing some new faces, so if you could just introduce yourself, can we start with Sarah? Welcome.
Good morning, I'm Sarah O'Curry. I'm Head of Psychological Services for Paediatrics and Maternity, and I'm here with Gemma and Susanna Watson, to talk about the Cambridge Centre for Paediatric Neuro Rehab.
Okay, looking forward to hearing that. Welcome. Who else have we got? Look. Ranjant Shan, have I pronounced that well? Apologies if I haven't. Can you hear me?
Yes, you have. Yes, I can. And my name is Rajnikant Shah. I'm newly appointed governor, and I've been a member of the Patients Partnership Forum, and also served 3 years at the Mental Health Network as a director. So you could call me Raj, R-A-J. That's easier than Rajnikant.
Thank you very much.
Thank you.
Thank you, and welcome and congratulations on being appointed the new governor. Who else have I got? Hakan? Have I pronounced that right? Welcome.
Yes, thank you. Good morning, everyone. I'm Hakan, one of the new appointed public governors. I'm a medical practitioner. Thank you, everyone.
Okay, and welcome and congratulations on being appointed new governor. And then
Thank
Gemma and Fiona. I think I recognise you.
Yeah, I'm Gemma Costello. I'm here with Sarah and Susanna to talk about the CCPNR.
Okay, then I think that's everybody. Welcome.
Well,
Fiona, sorry, apologies.
Hi, I'm Fiona Kerr, and recently elected public governor, Cambridgeshire.
Brilliant, thank you, and congratulations on your appointment. I look forward to working with you. So I think we will get straight into it. We've got a board story with Sarah and her team. So, and I know you do some exceptional work because we've heard it before. So over to you.
Thank you, Chair. I'm going to introduce us as we sit. The Cambridge Centre for Paediatric Neuro Rehab sits underneath the Psychological Medicine Service, which is a partnership between CPFT, Adam Brooks and North West Anglia Foundation Trust. And we work all the way from hospital admission all the way out through to the community. We're going to talk about the acquired brain injury pathway, some of the opportunities that are coming up currently for us as a trust, and then get into some of the detail about what work happens in the CCPNR with some patient voice as well. So I'll hand over to Susanna to take it from here.
Thank you so much. And Natalie very kindly said that she would share the slides. I'm not very proficient at saying next slide, please. So Natalie, do chip in if I haven't said that, obviously. Yeah, so the CCPNR sits under the Psychological Medicine Service. Next slide, please. And we began in 2009. We're a regional interdisciplinary community neuro rehab service that is able to see children up to 19 years old if they're accessing education. It was a collaboration between the Oliver Zangwill Centre and Adult Neuro Rehab Service and CAMS, and originally we had 9 patients funded. It's neuropsych led, but it's very interdisciplinary. And when we started off, we were out in Ida Darwin, very isolated, and children could wait on average over 3 years for a referral. And now we have this pathway from the ED all the way out to community, which is a collaboration across the different trusts. We've got an ABI clinic that has provided over 1,000 appointments, and it's a tiny part-time team. It's only 4.2 whole-time equivalent. And for us, it's a real privilege to get to be here with you at the board, and we really welcome and are grateful for this opportunity to get to have some feedback and think about where we're going. We're a constantly evolving service, and all feedback is super welcome. So I'm hoping that we can have 10 minutes afterwards to be able to get your views. Next slide, please, Natalie. So just as an orientation, we think of ABI as an umbrella term, including children with traumatic brain injuries, strokes, infections, tumours, and there are other causes that people will know of hypoxia and conditions that cause an injury to the developing brain. Thank you, Natalie. Next slide, please. And this is really important for me, thinking about the trajectories that children go on, the developmental trajectories after an injury, because people used to think kids just bounce back after an injury. And children do often make a really good physical recovery, and that's what people see. But actually, it's only by tracking downstream what happens that we know what happens to children's brain development. And it's not an easy picture. So if you think about somebody's mental age on the left and their chronological age on the right, they make that quick recovery and they get discharged from hospital and go out into the community. But it's only by tracking them that we get to see what happened. And often then with their damaged brain, they're having to learn new things and struggling out in the community. And so they've been really invisible. Natalie, could you just click for me? So we don't see suicidality peaking until 5 to 7 years post-injury. And the prevalence estimates of offenders to have reported a brain injury are between 50 and 70%. And if you think about how the frontal lobe develops, that ability to inhibit your responses, you can see the connection of how people who might come from a background where they're really struggling already, who end up getting into trouble, they hurt their brains, and they don't have the support around them to be able to cope. Those are the children that we see going onto the criminal justice system. Next slide, please. So it's a really hidden pandemic, and there's very little training out there for people to understand about brain injury. There are limited resources. The CCPNI is the only regional service in the country and is now being considered as the gold standard that we're hoping to replicate nationally. It's a huge health inequality, and these young people are overrepresented in exclusion and youth justice. Next slide, please. And we've been starting to contribute to the evidence base. In the east of England, we know there's over 1,000 young people with brain injuries a year. We know they've got the same mental health needs as children in CAMS. We know the earlier age of injury, the worse the outcome. And we know that specialist intervention changes their trajectory. And not only does it help them clinically, but this reduces the financial burden of their needs. The biggest thing that children want is to be able to participate with their peers. And at the same time, their parents are most likely to be affected by PTSD and low mood. Next slide, please. Just going back to that last slide, sorry, could you go back to the last one about what we're learning? I forgot to say that the parental response is really important, because it's the parents who are doing all the rehab at home. They get discharged home, and if the parents can't drive their kids to an appointment, they're not going to have it. So if you've got a hypervigilant parent who's unable to leave the house, they're not going to be able to engage with services. Thanks. Next slide, please. We've looked at the goals to look at what children are asking for in terms of rehab. Next slide, please. And the top goal is about being able to access education with their peers. The next one is about being able to regulate their emotions, and then it's about support and relationships they need to be able to function in the world. Next slide, please. And if you ask most children what they want, it probably looks quite a lot like this. But it's not easy when you might not have the ramp you need to get into school, or to leave the house, or to get on the bus, or your mum's got PTSD so they can't get you out of the house. So sometimes it can be a small intervention that makes a massive difference in the trajectories of these children's worlds. Next slide, please. So we're really lucky to, with CPFT and CUH, be able to work across from PICU all the way out into the community. And with pediatric liaison and the psychological services here, we can work into PICU to be preventing PTSD with the family. We can be working on the wards. We can be preventing post-traumatic amnesia from being prolonged. We can see them in an outpatient clinic in a collaboration to follow them up. And then if needed, they can go on to the CCPNR. But a lot of the work happens in supporting local services to be able to meet their needs. So when they're on the ward, when they're at the ABI clinic, we're already working with local services to skill them up and think about what the child's going to need locally. Can you click, please, Natalie? And being in Cambridge, we're so lucky that we've then got amazing research across the pathway. So we've just published a paper with the brain physics team looking at what happens when we regulate the cerebral perfusion in children's brains. And we've also then got research down the line looking at how we get these children participating in the world. Next slide, please. I also want to just talk about the cost savings of this, and they are massive. We just costed up 2 young people with a similar injury. So Lindsay and Jack both had the same kind of brain injury, but had a very different outcome. One had the CCPNR and one didn't. And so Lindsay didn't get to CCPNR until 4 years post-injury, and Jack got CCPNR and the service woven into his pathway right all the way through. And you can see the cost difference there. Jack had the right people in the right time, the right professions able to pick up on what he needs at each point to maximize his trajectory. And Jack, in the end, having done loads of work with his executive functioning with Cambridge Kung Fu, became a Kung Fu mentor, which is a brilliant thing. So he's now with an ABI teaching other young people with ABIs how to regulate their emotions. Next slide, please. I'm going to hand over to Gemma now, who is the clinical lead for the CCPNR, and she's going to talk more about what the pathway looks like. But I've got that image at the bottom. I think we're all aware of the commissioning landscape feeling like this at the moment. But since CCPNR has started, we've had massive changes in commissioning, and being such a small group of people, it's a small cohort of children, it's been a real challenge. Over to you, Gemma.
Thank you. So, thanks, Natalie. So in terms of our commissioning framework, as Susanna said, there's a huge amount of work in terms of building those relationships with our commissioners, supporting their understanding of children, young people and family needs following acquired brain injury. The importance of offering rehabilitation closer to home in line with our family's goals, but also in terms of the cost effectiveness and those downstream effects, particularly when we're working alongside kind of community services and partners to provide interventions that can then meet those children and young people's needs at the right time in the right place to get them on the right trajectory. Can I have the next slide, please? So as Susanna mentioned, the ABI clinic kind of sits at the heart of everything that we do for CCPNR. It's our kind of early intervention offer, if you like. So everything has started from the input we've had in PICU, kind of coming then tracking down into kind of seeing families at regular intervals, key points of transition, key developmental points, to be able to ideally provide psychoeducation, to be able to respond to any immediate needs that families might have in that clinic space. So you'll have your neurologist there, you have members of the CCPNR team, and then you have a voluntary organisation, the Child Brain Injury Trust. The aim is that we can then kind of provide the supports to local community services who can be meeting those children and young people's needs, signposting out into those services, providing them with information that they need about acquired brain injury and how they might then adapt their interventions or supports to be able to meet that child's needs. And then we monitor them kind of over time back through that clinic. There are a portion of young people, though, who do meet the criteria for that service specification that you saw on the previous slide, where they do require that specialist interdisciplinary input. And so within the team, we have neuropsychology, clinical psychology, educational psychology, speech and language therapy, occupational therapy, neurology, and a little bit of portion of psychiatry time for consultation when it's required as well. And essentially, it's like a one-stop shop for all of these young people so that hopefully they get their needs seen holistically and able to be able to support them in the longer term. And we have these various pathways of support where we can give initial assessment and community liaison into those community services, or where we can provide more in-depth neuropsychological assessment and then kind of support a shared understanding of that young person's needs, again, for community services and families to be able to support them in the longer term. And then there will also be those who require that more direct and specialist neurorehabilitation as well, which we'll come on to in a minute. Next slide, please. So in terms of what rehabilitation looks like, next slide. It can cover a whole range of things. We think about kind of cognitive rehabilitation, so thinking about the supports and interventions that children and young people need in the context of their neuropsychological needs. There'll be trauma-informed approaches that support young people and families to process the sudden events that they've experienced and to be able to kind of reduce some of perhaps hypervigilance or other symptoms that we might see understandably in the context of the trauma that they've all experienced. Susanna's mentioned Kung Fu. We have things like cooking workshops that are very much kind of about children and young people's everyday participation. They're about bringing young people together, sharing their stories, learning new skills, but doing that in a way that's through activities that are meaningful to them and that they can take back into their home and into their community. And for some of them, they've then gone on to go and choose to do kind of cooking, courses at college that have then kind of played into those strengths and skills of things that they've loved doing during their rehabilitation, which for the team is a real joy to see. There's information that's shared with community services to be able to support, and particularly schools, to support young people's understanding, to keep them there, to avoid the risks of exclusion. And then there's a lot of identity focused work that we do with our children, young people and their families, that reducing the risk of that splitting of self, that pre-injury, post-injury, remaining connected to who I am, who I continue to be, but also finding new ways to be in light of new and changing needs, as Susanna kind of referred to. And next slide, please. And I guess one of the beauties of the work that we get to do, and as we said, we're really keen to have feedback. We're constantly working within this kind of commissioning landscape that is changing and kind of thinking about how we support that model for our families and young people, and that we do that in a way that works with commissioners across our region. But I'm very fortunate to be part of a group called the National Acquired Brain Injury Learning and Education Syndicate, which is with the UK Acquired Brain Injury Forum. And through that, I get to represent CPFT and CCPNR and the neuro rehab pathway that we have in the East of England. And with that, that's taken us to contributions with the all-party parliamentary group, to roundtable events in Parliament just a few weeks ago, and more recently to a meeting which talked to the new report that's just been published around rehabilitation. So on the next slide. This report has just been published, which is called The Right to Rehab, and it talks about the cost of acquired brain injuries, which are significant when needs of children and young people, families are not met. The costs are really significant. I would just draw, it's one of the things that we're drawing attention to, and it is going to be really guiding the work that's being done around thinking about the future service specification for neurorehabilitation for children, young people and families in the future. And I guess the key thing for us to consider as well is being able to kind of contribute to this evidence through the work that CCPNR and the East of England Neurorehabilitation Pathway has been doing. The key thing for us as well is that it allows us to highlight the work that's been done in the East of England, and we're really fortunate we've just been made aware that the action plan that is due to be published by the government in the autumn is going to name the East of England pathway as a model of best practice. Which will hopefully allow us to have conversations with other areas around what future regional models could look like for children and young people and their families. Next slide, please. We just wanted to finish with a parent experience who very kindly has pulled together just a 30-second clip just to give a little bit of an insight from, we've talked to some of the work that we do, but as to how they've experienced the support and the service that they've had. I think the fact that that parent has completed that as well in their car almost immediately when we reached out to our families and said, would anyone like to provide something? I think kind of speaks to the importance of this kind of pathway and the difference that it makes for families. And as she talked to you there, the importance of having that over time in being able to respond to emerging needs that happen for children and young people. So that kind of brings us to the end of our input, and we would welcome any questions or feedback that you might have that might support us in our next steps. Thank you.
Thank you very much. It looks like Fiona has shot her hand up, so Fiona, do come in.
Thank you. The prisoner population statistics leapt out to me, and I saw a lot there of references to one episode or one instance or whatever. Is it that it's a service able to also accommodate for people who might experience repeat damage, possibly through abuse or such like? Because I suspect some of those prisoners will have come a route that it's been multifaceted, maybe the damage that's been done, and whether this is the type of service that can catch some of those people and give them a better trajectory out of that circumstance, or you get to refer people on.
We would absolutely look to do that. We work alongside the Youth Justice Services regularly with our children and young people and children's services as well, and the kind of liaison diversion services as well, so as well as SAFE and CASUS. So there's a kind of, we recognise that kind of multifaceted, the fact that our young people are often using multiple services as well, but what we're trying to bring is the acquired brain injury lens into that. So supporting that, and it might be sometimes that other people are kind of holding the lead professional role, but what we're kind of bringing is that neuropsychological understanding of their needs and perhaps how their interventions and supports might need to look. The Repairing Shattered Lives report is really helpful and insightful in terms of thinking about the risks of this group from a neuropsychological perspective, and then those that then have these trajectories around school exclusion statistics and then ending up within youth justice systems. And some of the latest evidence is actually reporting those figures as being within kind of 80+% of those that are going into the offending population with a history of an acquired brain injury that hasn't been recognised or supported at an earlier stage in their development.
Steve, do you want to just say something? Then Sarah, I'll bring you in, David.
Yes, thank you. I think there are a couple of things. Folks, what a fantastic presentation. And I don't know if any of you are ever nervous about presenting at a board, but if you were, then you did not show it in one slightest bit. And you know, we're really proud of this service and proud of the fact that you're able to demonstrate both your passion for this and also the outcomes. I mean, the outcomes around this are incredible. That slide, the economic slide, is an amazing one, but quite scary when you look at the stark difference between that level of intervention compared to a different level of intervention. Chair, I think there are two things, if I may. I think one is we often talk about mental health community, learning disability services, forensic services, children and young people. We talk about the word integrated a lot. And in the realms of mental health and LD&A, we talk about the biopsychosocial model, which is this triangle of what makes up people. And this service both demonstrates the power of integration as well as the power of actually looking at those 3 points of a person for a life journey. This isn't an intervention, is it? This isn't something that you just go into a service and say, here you go, thanks ever so much, we'll see you in 12 months. This is a life journey and something that this team should be remarkably proud of. And I think my question is, maybe not for now, and I'm conscious that there are governors on the call as well, which may have seen this presentation, so it may be helpful for the presence of time, Chair, that if we ask those questions, drop them over to us and we'll respond to you to give you a bit more detail so we can move through the agenda. But I'd like to offer a cup of coffee to the team to talk about what we can do collectively as CPFT as we move forward, particularly with realms such as the Children's Hospital that's being developed that really strengthens this integrated offer. So it's a bit of an offer for a cup of coffee, but normally when I do that, that means that they'll bring something with an ask, Chair. So I'm very conscious, folks, that you're going to bring an ask, but I'm up for it. but I'm really conscious that other people want to ask questions, but it may be best to do that through dropping an email in.
Is that okay, David, if you drop an email through, because I'm conscious of time? I think you're on mute. But from myself as the deputy chair in Eileen's absence, seen this presentation before, and it is exceptional.
Yeah.
An absolute brilliant example of joined up working and making a difference. So thank you very much, and I'll look forward to joining you with that copy. Thank you very much.
Thank you.
Okay, so I think we will now get into the main business of the meeting. And if I could first start with apologies, I think.
Yeah, that would be me. So we've got apologies from Pri Pinadua, Rachel King and Kathy Walsh.
And can I also offer Eileen's apologies? She's unwell at the moment, hence why I'm sitting in to chair this meeting. So thank you very much for that.
Chair, we'll also receive one public question, which we'll take into item 9.2.
Okay, thank you very much for that. Next on the agenda is declarations of interest. I'm looking around the room. There are none. Then if we can then move on to the minutes of the last meeting. They've all been circulated, and I think a number of points have been.
So there's two very minor changes. There's a missing "the" in 5 minutes, which I'll pick up on the master set, and there's a pound sign and a percentage got switched. So in a finance section, which totally changes the meaning of it. So we'll get that change on the master version as well. But so we'll pick those up.
Okay, so there's no other comments around the room. We'll take.
Sorry, I've got one change, but I'll pass that to you. It's about the reporting of some information under page 7.5.25. We're going to P&C, not BNP, but I'll make that.
Yeah, we can take that. Yes.
Okay, thank you, Steve. Rudolph?
There is a comment that we have no female psychiatric beds in Cambridgeshire, which I think probably meant female psychiatric intensive care beds. But I gather it was what was said, but nonetheless, just a recall that we do have some.
Okay, round. Okay, we'll take the minutes as accepted then. Move on to the action log. I believe. Looking to my left. One is yours, if you want to talk to that, and then Holly.
Yes, no problem, Chair, thank you. So the action was a update on the board assurance framework, which ironically is a little further on the agenda. So the board assurance framework is to be updated, provided in August with a refreshed version of this in September. And I'm delighted to say, working with the company secretary to do an evaluation of that. Chair, you'll recall that we said we did that, and we were going to do that as a result of the publication of the NHS plan and a reset of our organisation post our CQC report, both of which have now been released, meaning that we're able to do that piece of work. So we will see that through August and into September, and checking with the company secretary presented at the board in September, Martin.
That's the plan. It may be an iterative process where we get to the point where we're all comfortable with it, but that will be the start point, and there's a paper that I've started writing.
Thank you very much.
Okay, thank you very much for that. So that's carried forward to September. And I'll look to you, Holly. The next two are yours.
Yeah, thank you, Chair. So in terms of the disability service, I can confirm that CPFT were given a direct award for a period of 1 year for the health elements of the learning disability partnership, and transformation work led by the ICB has commenced, and we've got both operational and clinical colleagues contributing to that. The award of the act was to deliver an as-is service, so I know there was concern around impact on service users in that particular patient cohort, but for the next year we are delivering an as-is service, and any new pathway will be co-produced, so we will be involving both service users and their families and carers. And then in terms of my second action, Chair, so there is a detailed plan sitting behind the reduction of inappropriate out of area placements that will be presented at the next BMP and then can come through to
Any comments on that?
Yeah, just very brief. Just to say thank you to Holly and the team, including the directorates on both of these issues, because it's a really obvious statement to make, but these are really important issues, both for local people as well as the continuity of the service and the care that we provide. It's one thing I'm delighted about with the as-is services. It gives us time to demonstrate continuity while we're doing the review. That's really important, so we don't start something. That will also, I'm just checking with the Chief Operating Officer, also route through quality and safety, so that we will take that through Q&S in terms of kicking the tyres in terms of what the changes are that have been made, make sure that this is both in keeping with up-to-date practice, best practice, as well as what's best for local people. And then the second issue, Chair, I think this is a long-standing issue with many organisations around the UK of this, the wording that nobody likes, which is inappropriate and appropriate out of area. I think it's safe to say that there is a huge amount of energy and work in this space. It's fundamental to the delivery of our core services. It is disruptive for patients that need to leave our area to be cared for elsewhere. And it's incredibly costly when it starts to be difficult to manage from a distance. And so it is a piece of work that we'll be bringing back. And I think, again, through quality and safety, anything that's been put in place will be picked up. I'm also delighted to say, Chair, that that has also been identified as a point of reference for our new ICB as it forms, with a sense of looking at our service specification review and asking whether this trust can provide additional support to what is classed as appropriate, which is services that we're not able to provide because we're not commissioned to provide. However, there is a conversation now to say whether we can provide those with the right level of resource. So there is a conversation, and all of that, all the business cases and all that stuff, Chair, if I'm being really honest, is important, but not as important as making sure that local people don't travel a distance to get the care that they need. So that's our principal core business here.
Thank you. Mike Chilcoin?
Thank you, Chairs. Can I just expand on that a little bit? So I think we need to get the balance right between out-of-area treatments as a expensive way of caring for our patients and repatriating it is a better way of managing our resources. But there was a report that came out last year nationally which showed that the outcomes for patients who were treated as out-of-area in community, both the quality of care, the fact that relatives are a long way away, but also suicides, rate of suicides was increased. So there's a big quality and safety issue, as well as the better use of resources, which is why Q&S is concerned with it 100%.
Okay, thank you very much for that, Mike. Some important points there. Okay, if there's nothing else on the actions, we'll move on. The Chair's report, and I will take it as read. Just a couple of points I want to make on that. Firstly, to welcome Peterborough Cardinal as our new non-exec director, formally appointed at the Council of Governors in June. In terms of the board development session and our private board, we focused on the financial position of the trust, and that continues to be a key focus for us. We've also approved the submission of the annual report and accounts to NHS England as required. And our development session focused on the trust efficiency programme for 25-26. No doubt we'll hear a bit more about later in the meeting.
Hello.
We've obviously got further NED recruitment to do later this year to replace Brian, who is due to move on, an Associate Director for Communications and Strategy, and that work is underway. The CQC report, which again we'll hear about, was published. As a trust, we were graded as require improvement, and I know Eileen and the rest of the board thank the work that we've all put into that. But I would suggest that the true work and the committed work is going forward to make sure we have a trust that delivers the service that we need to for the communities that we serve. Last but not least, and because we've got some on board, we've had the election of governors, so welcome again. And I see we've got 3 new ones, so lovely to see you and work with you going forward. And any questions?
Can I ask?
We'll move on to, somebody's got their, oh, got some interference there, so apologies. If that, I'll move on to the next agenda item, which is our Chief Exec's report, unless there are any questions. Okay, over to you.
Thank you. Thank you, Chair. And I think I'd just also wish to extend the significant congratulations to Professor Cardinal. Welcome to the board. No pressure. So it's fantastic to have you with us. And also the same congratulations and welcome to governors that have joined us. You're joining us at a really interesting time. And the reason why I say an interesting time is because certainly over the last 4 to 6 months, what we've been doing as a trust is trying to take a really hard look at where we are in both our system against the NHS plan and also where we are against our own standards. And I think the CQC report is a really good example of a reflection in the previous period as to where the organisation has come from. That is not determining where the organisation is going, however, which is a different route, which I'll land on in a second. I'm also conscious, Martin, that we have a question under the CQC report under 9.2 that we'll be picking up. However, what I may do is I may inadvertently answer that question in terms of my quick update against that report. So just in keeping with time, Chair, if we run out of time, I've run on, then that will be my apologies. So quickly just going through the report, if I may. I think the first is the CQC well-led inspection. So the CQC did an evaluation over February 2025, which concluded on the 18th of July. The process that then goes forward is that the CQC take a triangulation of historic documentation and evidence, board papers, committee papers, or conversations to do with our partners. They use
Can I ask a question?
I'm really sorry. At this point, I'm afraid we're not able to take questions from the public because this is a meeting held in public, not a public meeting. So we do have those questions under 9.2. And the other concern is we can't see you it's in terms of any microphones. So apologies. Would you just type in the chat and if you maybe just present your question, we can try and answer that for you. So I'll just pick up the rest of the report, Chair, on this basis. So the CQC did their evaluation, which then presented.
Can I ask a question?
Can we just, Natalie, can we just pause for a second?
The family contribution. Family contribution.
I'm not sure what's happening because everybody's on mute. So if you leave it with me, I'm going to see if I can work something in the background.
I think this is a technical issue. I think it's a delay from a question that somebody was trying to ask in the previous presentation, and that's a very poor connection. And I think it's David Shaw.
Oh, it was maybe David. So
yes,
that makes sense.
Yeah.
Oh, okay. Yeah, that's a good point. Yeah. David, if you can hear us, I'm sorry your internet connection is. I think you're right. It's causing us a bit of a delay. So, Chair, in terms of the well-led, so that's resulted in a report that has gone to be published after it's been factually checked by our teams. And I'm delighted to say that the CQC has accepted all of the changes that we made with some of the areas that they had checked that weren't entirely correct. That said, Chair, the report also indicates some areas of incredibly positive best practice. So really solid in terms of a lot of the service offers that we were providing, our research was seen as inspirational, and some of the areas of leadership across the organisation in some of our services was seen and recognised as very best practice, which is great to hear. It is also safe to say that the CQC had taken stock from a number of our staff groups, and it reflected what they'd said over the last couple of years as to how they felt the organisation was moving forward and how they felt working within it. And again, as much as that can be difficult to read, it's a true reflection of where the organisation has been. And I think that is an authentic reflection as to where the organisation has not been able to guide through this next chapter or that chapter in a way that staff felt comfortable. However, and I'll ask the Chief Nurse to comment on this, who was our lead for the CQC, I am very pleased to see that the CQC reflected that when they visited, they mentioned the words green shoots and emerging changes already, and that was in February, because the board will take assurance in the fact that when we did our own self-assessment, Chair, in October to November, we decided quite rightly that those findings were not going to be things we would wait for. We would implement changes, which the CQC have recognised. So although the rating goes from good to requires improvement, which is a period of a significant time before we were evaluated, I actually believe that that gives us a really solid platform to move forward on with a series of areas that we know have been the reflective areas that we wish to change anyway. Can I just ask the Chief Nurse to comment, please, before I move to the next bit of the report?
Yes. Thank you, Steve. I think it's, as you've said, the positives, but I think it's also very important to recognise when we had the initial CQC feedback, the feedback that we received, there was nothing new in the report.
Yes.
Subsequent to the feedback, and also very importantly that there was absolutely nothing that we didn't already know about, and we weren't already aware of those green shoots, as our Chief Executive explained. Where we are at now is we have a clear assurance process in terms of the well-led plan, well-led improvement plan. I won't go into detail, but that will be shared subsequently at Quality and Safety and each of the respective committees next month.
Thank you. And we'll be bringing regular updates through the board, Chair, in terms of, and I wish to say thank you to the CQC, but I know this is a public meeting and I don't mean to be critical of what I'm going to say next. We shouldn't need and don't need a regulator to give us that level of sense of where we need to go because we were on that journey. It's incredibly helpful that they validated that, but we owe this to the people that we serve, we owe this to our staff and ourselves to get this right anyway. So although you'll see a CQC report, this will be more about us as an organisation rather than just responding to a regulator. Please, Rachel.
Apologies, Chair. One more point to add to that is that we have regular quarterly engagement with CQC, and as part of our improvement plan, we have also instigated additional bi-monthly. So we will now be meeting with them bi-monthly to ensure the progress is monitored with our CQC colleagues.
Brilliant. Okay. Thank you. If I then skip over because of presence of time, the follow-on from that is something called the High Performing Organisation Programme, which ironically was the thing that we put in place around October, November to guide us through this chapter, which, excuse me, is referenced in the CQC report. And that's how we are aligning our 8 key areas and 8 pillars of the organisation to look at moving us towards an outstanding level of service that we wish to give. So I think that structure, that framework has been through the board a couple of times. And likewise, that will start to form part of the assurance methodology of the plan, along with some of the other strategies that we're developing, including the areas such as clinical strategy, which the CQC identified, which will be coming through to the board in October towards November time. Likewise, the health population strategy, which is equally coming forward and embedding population health and public health, Marmot principles and social value into our clinical strategy, and things such as the EDI strategy, which again, ironically, are on our agenda. So it's really good to see that they caught us at a point in time. We've shared this with our workforce, we've shared this with governors, and we've shared this publicly because I think it's really important that we do so. And as a trust that really cares, we need to make sure that we genuinely reflect on where we've been in order for us to move forward. The NHS 10-year plan, Chair, was launched a couple of weeks ago. The plan talks a lot about those 3 key areas that the Secretary of State is focused on, as is our new government, or not new anymore, but our government. And they are those 3 areas such as moving away from hospital to community, moving from analog to digital, and perhaps embracing AI, and then moving away from disease to prevention. 3 things that we would see front and centre in our strategy as an organisation as well. And therefore, what we've done is that we have just put a half step in place with the presentation of our new strategy, Chair, to make sure that we take into account all of the findings of the NHS plan. Hence, that will come forward towards the board and the committees through September through to December, so that we can take into account all of those new objectives. I met with a range of chief executives from mental health, learning disability and community. And I think it's safe to say that the sector believes that the NHS plan would benefit from more input around sort of mental health and community. And so I think there will be some additional work over the next couple of months to support the NHS plan to make sure that the voices of our communities are not lost in the other priorities. And we would say that even if it was there, because we feel passionate about it. Chair, I'm going to end on two very quick points that are incredibly positive. And Chris, I don't know if any of our viewers are from the press, and if they are, then I would urge you colleagues to focus on these two positive bits, because these are really special. So the first one, which is really powerful, is this trust has become the first NHS trust in the country to achieve a gold award for supporting kinship with our members of our staff. That is such an amazing thing. And if any of you need to Google what that is, just Google it twice, because when you read it and you read it again, the care that we offer to our members of staff that look after children at a time of need, when they need it, is exceptional. And to be seen at that level of gold award in the country, being the first trust, is an accolade, but it's a reflection of the practice that we want to see with all of our services. That is amazing. And a massive thank you. It's been a journey of several years to get to that point, and with a whole load of additional support to allow staff to support those individuals at their time of need whilst they're managing a busy job is remarkable. We're happy to share that with other organisations in the journey to make sure that they too can get to that space. But again, I would urge anyone to focus on that. The second, which is marked as an academic piece of work, which is much more than an academic piece of work when I read it, and I've seen this with Dr. Liliano. So Lily and her team are doing some work around some breakthrough treatments for PTSD, post-traumatic stress disorder. And anyone that has experienced any of these services knows that's quite a tricky area to work in, with a lot of complexity. And their piece of research has led to the first new treatment for PTSD to be published and then to be deployed in over 20 years, Chair. That has come from research that's been applied and then delivered through our services. And this is the first type of this treatment that has been put into the NHS in over 20 years. Lily and the team are remarkable. And the way that they've worked with our patients, it's been co-produced, and the way that it's deployed through an applied research in partnership with our partners at the University of Cambridge and other universities, I'm just saying a massive thank you. So there are two really fantastic stories to end my report on there, Chair.
Thank you very much. And whilst we're on to, I'd like to just echo what we heard earlier from the team in terms of the fact they're leading change nationally and some of the exceptional work that they're doing there. So I think we've got a top three we need to echo and be exceptionally proud of in terms of the team and the work they're doing and lives, changes to lives they're making. So thank you very much.
Yeah, just a comment to pick up on the point about the CQC recommendations going to the subcommittees. Really looking forward to seeing those in August, as I'm sure other chairs are coming through. Suggestion is, if we in doing that, can we set them within the HPOP, the High Performance Organisation programme, given that the programme anticipated one of the recommendations, it would be helpful to try and stitch the two together as we see it going through committee to the meetings in August.
Absolutely, thank you,
Steve.
And
Mike?
Yes, and just a comment or question, which is around the internal comms and external comms around the CQC report. I don't know if there's anything you feel able to say about that, Chris, but I think it's very important that when this report comes out, we attend to what our staff feel about the results, requires improvement, and the public who are going to use our services and what they think about CPFT as a. Yeah.
I mean, if I may just give Chris a second just to think about this. We've shared this already, Mike. The report has been published, and we've engaged with the staff on a number of ways to ask them what they think, how they feel about this. But more importantly, as a collective leadership for everyone in the organisation, what we do collectively to work forward. I think the bit with reports such as this is they are at a point in time. And what we need our staff to do is to really reflect on the things that they're proud of, not to feel criticised, not to feel that the organisation isn't a supportive place for them to work and thrive in. And likewise, that goes from managers right the way through to our clinicians. The other thing that we need to be able to do is to listen to the improvements that they wish to make as well, because one of the things that the organisation has seen, which has been reflected back to it, is perhaps that set of voices weren't listened to previously in the way that they could have been. And we've made a commitment to make sure that that is clearly the case. I think the strategy for this organisation as we move forward will be better for it. But what we need to do is to make sure that members of the public or members of our workforce still feel confident. And I used this phrase the other day, irrespective of those challenges, thousands of interactions of care happen every single day, all of which are incredibly positive. We look after some of the most vulnerable people in society, and we should be proud of what we do. Having the mirror held up to us, as every organisation does through our regulatory process, is incredibly useful, but it shouldn't stop us from being proud of what we do clinically every day. Sorry, I know Chris wants to come in. Thank you, Chris.
Yeah, thank you. I think just on the point around the internal comms, we're committed to kind of keeping the staff updated. And actually just last week, we had 398 members of staff on an all-staff call with the executive team, in which we talked through some of the findings from the report and the consequent sort of improvement plans that have been formulated. So when we think that that's just shy of 10% of the organisation in one go, that's a decent number. And we've got a clear plan of engagement events coming up over the next few months to make sure that people are owning what's coming through from this, and that it's a we.
Thank you. Appreciate that. Thank you very much.
Thank you very much. Steve, come on in.
Just really quickly in relation to the trust strategy. I mean, one of the really important pieces of work clearly for the organisation, and now that we've got the 10-year plan, we've got the CQC feedback, we've got the HPOT programme running, we really are going to sort of focus significantly, and apologies, Chris, I'm looking at you and other colleagues here to support around developing that trust strategy. One of the bits of feedback we've had from our staff is that they actually want to be engaged. Now, this is going to be quite resource heavy, so I'm just letting board know they physically want us to go out. They want to sort of walk the boards, you know, as and I think Eileen's very supportive of that. She says that quite often. So we are going to start going in, doing workshops actually on the ground across the organisation. We've got 49 different sites. So we're thinking at the moment, how can we do that during August and September? We will be reaching out to NEDs as well to be part of that process, and also governors. And at the same time, both MWAF have just reviewed their strategy, CUH have just reviewed their strategy, let's link across. And we are linking across this week with Capworth, who are currently reviewing their strategy, and Steve and I got a meeting as well to make sure there's a synergy between the system as well. So obviously we'll be reporting back through BNP on that work and looking to bring that to board in about October, November for formal sign.
Okay, thank you very much. Back to you.
We can take the next item, Chair, as read. I think we've picked on the action plan around the evaluation. There's one point of note, I think, which is really helpful in the first part of the board assurance framework, which is the relationship with our partners. And I think I would say that it's improved. Our partners have reflected that it has improved, which is great. However, I'm also really conscious that most, if not all, of our partners are equally going through difficult times themselves. And so I think both from an organisational architecture point of view, with the changes at an NHS level, right the way through to operational challenges that some of our partners face, it is really good to see that as chief execs and as directors, we get together regularly to talk about those, share best practice, and sometimes challenge each other to make sure that we get the right outcome for patients. One area that I think is going to come back to this board, but it is in relation to that first BAF area, is the review of our community services and our mental health services. And the board will recall a comment that we made previously, which is those systematic reviews of demand, capacity, efficacy of service, demand profiles around population need, etc., haven't been done for a while. So in excess of maybe perhaps a decade or two. And so a really good opportunity for us to reset the needs around some of our services. Professor Cardinal raised the issue in the minutes to correct the statement around female provision. However, that reference that Rudolph mentioned around the lack of provision for psychiatric intensive care for females, for ladies, is going to be part of this review, because it has to be a needs assessment for our population. which is a good thing for us to be able to demonstrate where that need is. But that will be in addition to when we report back in September.
Okay, thank you very much for that. Any comments or observations on that? Are we happy to move on? Which is over to you, Mike.
Thank you, Chair. So I'm reporting on the last meeting of the Quality and Safety and Patient Engagement Committee, which met on the 18th of June. And so I've got a few points to make. Some of them have already been made, actually, around out of area placements and the relationship between quality and safety and the lack of female PICU beds. But I would alert the board of the fact that we're still working hard to re-provide ECT provision in the south of the counties. We're assured that patients can get treatment in Peterborough. There's not a lack of access to treatment, it's just travelling a long way, and we feel that that should be re-provided as soon as possible. The other thing that I'm thinking about is giving greater scrutiny to the physical health metrics that we look at in the Quality and Safety Committee, as well as the mental health metrics such as falls, tissue viability, and we will be doing that going forward. And we were assured that work continues on the patient care and race equality framework. We, to some extent, thanks to Jonathan Wells, had a very good look at the NHS Community Mental Health Survey 2024, which is here. And as I said at the last board, we're going to give that survey parity of esteem or the same attention that we give to staff surveys in terms of how do we respond to the findings of that. Now, too, is going to come back to the August Quality and Safety Committee to look at the action plan, which is to some extent linked to the implementation of Dialogue Plus, which is making progress. Just a few other points. The Beacon service, which is a new outpatient service for eating disorders based at the Ida Darwin, is established, but they've extended, I think, the review period, and it's, you could perhaps add up to this, but the Beacon service is going to be reviewed in about a year.
So it's 6 to 9 months, so it's the day service.
Yeah.
Apologies, I'm correct, instead of outpatient.
Absolutely right.
Day service, and they've extended the pilot for another 6 to 9 months to allow further collection of data, so that we can be clear on what needs to be commissioned going forward.
So the relevance of that is quality and safety want to be assured that the outcomes for patients are as good as they can be. We receive the annual sexual safety report and the annual safeguarding reports, and it was interesting to see the increased focus on their work with regards to prevent and radicalisation and terrorism. Do that work, but I think that's perhaps going to be something we need to give greater attention to going. We also get, as part of the operational plan, directorate level insight into how they're approaching the financial SIP programme and how that relates not only to the financial savings but to quality and safety, which is good to see. And we received the smoke-free report. I understand it's going to be illegal to smoke in NHS premises by 2027. So it's good to see that we as CPFT signed the NHS smoke-free pledge back in 2018. So we've been on this. And 2 areas of substantial assurance were learning from deaths and the theory of suicide group, which is working well, and also the medicine safety optimisation and pharmacy report, which gives us substantial assurance, including the appointment of the medical safety officer in place and the work they're doing, for instance, on electronic prescribing in inpatient wards, and the oversight that we're having to give to female patients who've been prescribed valproate, either for bipolar disorder or epilepsy, because of the they need following up, and that is happening. In terms of assurance, the patient safety incident response framework is getting embedded. The new incident safety panel is complete. We've got 2 new safety partners, which is great. They're part of the NHS patient safety strategy, and they attended the meeting in June. We've got the compliance executive group, which will be looking at both internal and external quality assurance, with an aim to undertake one quality assurance visit internally across CPFT services per year. And lastly, I know it sounds a small thing, but I, as a GP, was rather pleased to see our infection control manager undertaking a car boot care audit. Now, this was looking at our community staff and making sure that the standards of infection control hygiene are as rigorous in community settings and domiciliary settings as they are on our wards, which I thought was great. So, finish on that point.
Thank you very much, Mike. Question here from Rudolph. Do you come in?
Thank you very much. It's terrific to hear that there's progress perhaps happening on the ECT front, because it's been quite a few years, isn't it, that we've been without an ECT service in the south. And just to add, there are some situations where we can't transfer people to the north, and then the current process of replacing that, there is one, but it is not very satisfactory. So it's terrific to hear. And that's a multi-system question with multiple providers involved, as we perhaps said it. So, thank you.
Thank you.
Just a very brief point, Mike, maybe not for now, but for the committee in terms of the annual flu uptake. I think most providers, including ourselves, have seen a decline in the annual flu uptake probably since perhaps vaccinations in COVID periods, etc. And I think we just need to make sure that we are trying our best to provide both advice, support and accessibility for that as much as possible, particularly as I know it's 23 degrees today, but it won't take long before it's winter. So we need to just start thinking about that. If I can ask the committee for some assurance on that, not the fact that I've had my flu jab, and when I had my flu jab, it was fantastic, seemed great. It's just that we maybe need to do something slightly different to allow access to be improved, such as the innovations of car boot things, for instance. I just think it's worth asking the team, is there anything else we can do to support staff?
You want to come in?
Yes, certainly. So August is the planning month. September is the communication and staff engagement, and again, also linking in with other trusts across the area in terms of learning, and obviously October is the delivery. But I had a supervision with our head of infection control yesterday, and they're well advanced in that. We just absolutely expressing what we need.
Thank you.
Thank you. Good to hear. Is your hand up?
Yes, please, Chair. It might be worth noting that in the urgent and emergency care winter plan, it is a requirement for all NHS trusts to look to improve their flu vaccination rate by at least 5%, but they're looking for more if they can get it. And boards are required to sign off the plans to provide assurance, so we'll be looking to do that.
And has that, just a quick question off, obviously, Steve, has that national requirement been communicated to our staff?
Yes, they are aware. Yes.
Yeah, it's just a point of detail. The Eating Disorders Service commissioning, is it until another 6 to 9 months, or is it to the end of December this year? I think we told previously it's in.
Yes. I'll defer to Holly.
Undefined at the moment. So at the moment, we've got 6 to 9 months. And the reason is because we are one of 4 other services, and they're wanting to get the sort of wealth of data collection across the services so that they can look at it in the whole. And we were the first service to get up and running. Others have been slower. Hence the reason that they've sort of said 6 to 9 months. At the point they feel that they've got a data set which is useful in order to look at the efficacy and deliverability of the service, then they will do so.
Okay. Then just one comment for me, the patient safety partners now sitting within safety and quality. I think that's an excellent move.
Yes,
no individual can live experience, yeah.
Chair, if I just expand a little bit, they're both very experienced and knowledgeable people. One with personal lived experience of mental health services, and the other working very hard in the context of physical health and specifically multiple sclerosis. So they're going to bring a lot of patient insight into quality and safety, not just clinical, and not on their own. but they're great people and slightly personal point, but they support me as chair as well. They give me assurance that we're on the right track. So it's very helpful to have them.
And I'm sorry to jump in, Chair. I think this is fantastic because often you see individuals with that lived experience attending meetings, but not able to shape the business. And I think this is such a good move. Really, really good.
Thank you very much. Okay, we are now moving on to quality. Rachel, you're on.
Thank you, Chair. As always, take the report as read. I've got 4 issues I'd like to highlight. First, in terms of the debriefs, in terms of and explaining the work that's happening to improve this situation. Obviously, everybody understands that post-intervention debrief provides an opportunity for support wellbeing and enable learning across teams. Obviously with a view to avoiding further incidents. We do have concerns currently in that dialogue is that debriefs are happening, however, the data is not showing that enough. So we are doing some, the teams are explaining that it's probably retrospectively being recorded, which again is understandable, but it's giving a mixed picture in terms of our data. So we have an improvement plan for this and also in terms of training and practice. This has been reviewed with a range of staff in September as part of the Safe Wards collaboration that we're undertaking as part of, in line also with culture of care. And we have a meeting on the 11th of August with our clinical nurse specialists who will then be implementing that in the wards and also with our CNIO supporting that in terms of improving. Secondly, just to raise that our older people's and community director also have a improvement plan for recording of lying and standing blood pressure on the inpatient wards. The data that you see in the pack is the May data. In June, there's been a demonstrable improvement, still not enough, going in the right direction. It's now at 14+%. So that improvement plan is clearly having some traction, and obviously we'll keep monitoring that. I'd also just like to explain in terms of pressure ulcers within how in terms of being managed within predominantly the OPAC directorate again. So all pressure ulcers are reviewed in terms of grading of 1 to 4. Those which are graded 3 and above are then subsequently reviewed by our tissue viability nurses and also mapped back of whether they're attributable, the word say attributable, to CPFT or not. And if they're not, then there's liaison with system partners like care, etc. Any that are attributable, like category 3 and above, there's then a local incident review for learning and health purposes. These are and all this learning is shared through the OPAC quality and safety. And there are also some issues within that have been recognised in terms of training, which again is being followed up in terms of the and lastly, I would just like to raise the ongoing challenge for us in our complaints management. This does remain challenging. We have seen in quarter 1 double times 2 the number of complaints in that period as per previous years. And obviously there's a resource issue here in terms of our services having the resource to investigate the complaints. In terms of the quality monitoring, that is now proven successful. We have reduced the time span quite dramatically. However, it's not being shown in the data, in the statistics, because there is still a backlog. So the team are now working on having a backlog trajectory plan and then the current. Thank you.
And I think, Chair, please, I am incredibly grateful to Rachel, the Chief Nurse, for taking on this portfolio, because the reason for complaints sitting within the quality and safety agenda is because they need to be investigated from a clinical perspective in the appropriate way that Rachel's just determined, but also that they inform lessons, they inform how we can learn and correct errors if they do occur. I think it would be safe to say that we would all wish to go on record for those people that have outstanding complaints to apologise for delays that are associated with those. Sadly, as an organisation, we do receive those complaints, but we need to do them properly to give them justice, to look into the details that you've shared with us. But for those people, both A, reading the minutes or B, listening to this, I think it would be safe to say we apologise for any unnecessary delays, but they are being reviewed.
Okay, thank you. And I think one of the things around the learning is what we can do to then get the complaint.
Just to add to that, Chair, one of the measures that has taken place in the last 6 months is for teams to be, when it's appropriate for them to be investigating their own complaints. It's that local ownership immediately. If it's not appropriate, i.e. more independence is needed, obviously that also happens. But we are certainly getting, that's certainly an improvement.
Thank you. Then if there's no more points on that, we'll move on to, I believe Sam is on screen, so Sam, welcome.
Hello, thank you, Chair. I'm going to take the report, Safeguarding Annual Report, as read, as Rachel said a couple of minutes ago, and just give a brief overview and then accept any questions. So as you all know, 24-25 and 23-24 even, safeguarding has grown, shall we say, within CPFT, but that's also part of a national projection as well, and coming out of COVID. The annual report really clearly highlights the developments that have been done within the safeguarding team. That is with alongside the challenges, and some of those being just the increase in numbers. But there has been some really nice achievements, and those achievements have been internally within the team, but also I think there's been achievements by the frontline staff as well, and their improvement in their skills and knowledge, which I think has been seen certainly and highlighted within the last year. You'll see that the report is about our internal work as well as our external work, and there are things such as training and everything else in there. And just to highlight really that I think that the team has shown real resilience in the last year and has really been adapting, and they've continued that into this year as well. We had a 3-year strategy in place. We've just finished the 2nd year of it and are going into our 3rd year, and we are on track with that. So I'm really proud of the work that the team has done, but also proud of the frontline staff that have really been there to help and support us get through that as well. So any questions?
Okay, Mike, then.
Oh, it's not a question, it's just a note of appreciation. You brought the annual report to the Safety Committee, which I made reference to, but didn't go into details. And it's to thank you as a team for the work we're doing. At the point that you look at safeguarding issues, not just for our staff, but patients, but you provide a service across Cambridge and Peterborough. And the complexity and numbers of referrals have been rising very significantly. So there's 2 points there. One is to commend your resilience in terms of coping with all of that, but also to recognise that is a growing pressure on your team. And we'll keep an eye on that as we get the quarterly reports coming through to the quality and safety. But it's just a thank you and appreciation for what you do.
Thank you. And just can I just answer that? In answer to that, there's 2 things I want to say. So that's one of the things where I think the team have been really impressive, because they've really took on board some of the IT new working models, and we've been piloting quite a few of them, which has really helped and supported, I think, the team in dealing with that increase in workload and the capacity. And the second thing is that's why this year there's a real focus on the training and getting the training right for staff, because actually what we want to see now is to improve the training and the skill set of the people on the front lines, that actually they start to take on some of the basic safeguarding, which is something that's should get more of a routine for them, embed that within their practice, so that then we can lift that work out of the safeguarding team's work, so that we can focus more, like you say, on some of those complexities and some of those nuances and new things where that help is really needed for those frontline staff. So that's the plan for this year for the team and for the trust.
Thank you.
Thank you.
Steve.
Sorry, thank you. Sam, thanks. Echo what Mike was saying about the report. It was just a point of detail on the domestic abuse reporting. The state of the report says there's been a reduction in November, but you think it might be down to an IT issue. I just wondered if there's any update you could give on that.
Yeah. As you've read throughout the theme, one of the themes through the report is the fact that we've been working really hard with our IT colleagues about trying to get some more robust data, because it's very reliant on staff who are very, very busy on the shop floor actually ticking the right thing within their systems at the minute. So what we're doing is we've turned all of that around. We've completely worked how they put a referral into the safeguarding team, and as part of that, it's now the team at the end of working with that frontline member of staff, the team member themselves now actually codes that case. So we'll code it appropriately with all of the elements of safeguarding that have been dealt with as part of that safeguarding support that has been given. That should really, really support and enable us to have better statistics, which will then obviously help us to then target what our training is like, and also to focus where we need to focus out some of our support through knowing where people are referring. The second bit is the fact about asking the question and routinely asking the question. So we're working with IT on that as well. And we've actually produced a new section that we're going to be embedding within the frontline practitioners' main work areas where they work when they're with the actual patient, so that they can just tick boxes to say straight away that they've asked that routine question. And so that again will then statistically be able to code. So we will then know how many people are asking that routine question every single time they see a client, because that's something else that at the minute that we can't gather statistics on. So yeah, we're in the process, and hopefully by the end of this year we'll be able to provide a lot more of that information, which obviously will be really rich, which will then enable us to then move into the next quarter or next 3 years of strategy.
Yeah, thanks, Sam, for the report. I think, it's a public board chair, so never waste the opportunity to embarrass somebody by saying that Sam's one of our superstars. And I think Sam, very, very well done in terms of both presenting the report, but also the documents within it. I mean, I know you're on top of the issues to do with training in terms of making sure we can get as far as possible with that, because it's so important. But Chair, it's a point of note that this service, this team, they deal with some of the most vulnerable people in society. And not only do you do that really well, but also when I talked about the NHS plan around this concept of prevention, this isn't what you'd see as prevention in the wider sense, but this keeps people in their homes. This keeps people away from institutions like ourselves, which is an amazing piece of work. It's an incredibly difficult working arena for Sam and the team to work in. But without them, we would be significantly lost, and our patients would need additional support. So the early intervention that they create, I think, is worth the note. So Sam, a massive thank you. Sorry if I embarrassed you there.
No, and just I'm just really pleased I'm not in the room, as Rachel will probably know. But yeah, I mean, behind me is my team, and I would be nothing if it wasn't for my team, because I couldn't be everywhere at once. So I am quite literally just the face, accepting that on behalf of everybody else within the team. But thank you very much. And I do see safeguarding as prevention. You're absolutely right. It's, we're gone from the days of protecting people into safeguarding people. Safeguarding is about that early intervention, which means you don't get to that next stage, and that's across the board from an unborn baby right up to somebody who's over 100 years old. So yeah, I do see us as a preventative service as well as a protective service when things have happened. But thank you very much.
Thank you.
Sorry, just to embarrass you a little bit more, Sam, just to say thank you very much for taking time out this morning, because I know what's going on behind the scenes. So thank you very much.
No, thank you. And I'm now going to hop off to a professionals meeting.
Okay, thank you very much. And I think we are time just. It's over to you.
Yes, thank you. Thank you, Chair. I'm going to give an update around the work that's happening in the space around assertive outreach, and I'll take the report as read, but I'm really pleased to be able to give an update and to provide the board with assurance around all the work that's happening in this space. It's a particularly an area that's really close to my own heart and close to my heart clinically. And to be able to tell you about how we're addressing inequalities in this group of our most unwell patients with psychosis is a real pleasure. So there are just 3 areas that I wanted to highlight. The first is the work that's been happening with the ICB since November of last year to benchmark against all of our service provision for people with assertive outreach needs. And that was off the back of NHSE guidance for best practice in assertive outreach. And included in that work with the ICB were several stakeholder workshops and also a high-level options appraisal around a service provision that would be fit for the future and a recommendation that we provide a dedicated assertive outreach service. The second piece of work is a piece of internal improvement work that we conducted within CPFT, and that maps to the independent inquiry following the care and treatment of valdecocaine, which came out in February of this year. There were 5 key areas that all trusts were asked to focus on, and we have conducted an improvement programme and done improvements in specific areas, but also mapped several improvements which are continuing in work streams, wider work streams for business as usual, such as Dialogue Plus and risk formulation and the out of area work that's happening. And finally, just to say that now we are pivoting that improvement group into a service delivery and programme board to deliver an assertive outreach service. So the ICB in May supported our recommendation that we need what's known as a full fidelity service. So that's dedicated service provision for patients with assertive outreach needs, and that needs to be provided county-wide. So we have commenced that work with a view that we will be ready to begin implementation from January 2026. Any questions?
No, that's good to hear that the ICB have stepped in.
Thank you. It's great to hear it's coming back. I guess it's just a reflection. It's a thing that maybe the NHS struggles with most, is where risks are severe but very infrequent. And then there's space for services to be decommissioned and nothing much happens for a while. And then the underlying need for them becomes obvious. And that's been made obvious at a national scale there. So I hope this one sticks again, but it might not be the last of those kind of situations.
Yeah, I would agree. I think perhaps it's the risk to others that has accelerated the re-looking at this service, but just in line with Sam's safeguarding report, actually I'm delighted that this has come back for the reason that these are our most unwell and very vulnerable patients, and that we can look after them better.
What makes this service review different than the general service reviews that the ICB is going to be taking?
I can probably pick that up, Kish. I think it's maybe not a difference of service review. It's a genesis as to why it was needed.
Yes.
And I think it was recognised as a significant national gap, and the tragedy associated with valdecocaine really brought that to the fore, where I think it was, as Rudolph said, it was a reactive approach to a review on the basis of service gap. I think we need to learn on the basis that, as Rudolph and Catherine quite rightly say, sometimes they're very infrequent, but when they happen, they're significant tragedies. And therefore there needs to be a huge amount of learning that comes from this. And there are sadly scattered reflections of that through the NHS over the last many years. When we do the routine service reviews, we need to make sure that some of the learning from that is reflected into that, but it's the genesis of where it came from, not the review, if that makes sense.
Yes, and just to add that the genesis is from NHS England, isn't it, as well? So this is happening nationwide, and we continue to report back and to meet their requirements. So this indeed is one of their requirements, that all providers report in public board on their progress with assertive outreach provision.
Yeah. Just one question for me, maybe not be able to answer it now, the impact on our capacity to deliver this service.
So are you referring to workforce risks in terms of?
Just, yeah, generally.
Yeah.
It's a new service that
Yes.
is clearly needed. There's going to be an impact on.
So that will all be worked through as part of the programme delivery board over the next 6 months. There is a workforce risk. What we see with new teams is that it tends to leach staff out of existing teams. So we will be very mindful of that in how we implement. So it will be implemented in a phased way. And we've also got some hybrid solutions around that will probably be attractive for recruitment and retention. Actually, these posts in terms of psychiatrists are very attractive posts because people want to work with our most unwell and to be able to treat them.
To be able to recruit psychiatrists, that's been an issue for some time.
I know this is completely unrelated, but certainly over the last, we've sat through a significant number of consultant psychiatrist appointments, and I am really pleased to say the organisation is receiving a lot of applicants at the moment for people wanting to come and work with us, much more than we did over the last maybe 12 months or so. And this is first appointments as well as secondary appointments and third appointments, so it's really good.
Excellent here. Thank you. So next, we're moving on to people and culture. I think we start with you, Steve, then Sharon.
Yeah, we are. Thank you very much, Chair. So I'm going to take the broad sort of report as read. I just want to draw 3 or 4 particular issues out. First of all, you'll have seen in the report around sort of the national approach to the job profiles. That's a significant piece of work that we undertake over the next 2 to 3 months. I think it's fair to say that's going to be quite resource heavy. It takes us back to the work that we reported up to board around bands 2 to 3 last year. This is much broader than that. This is bands 4 to 9. I know one of the questions from our chair actually was around, what's the impact? Well, part of the scoping work will actually give us that understanding of the impact. But I think it's fair to say you could, this is an example, you could have a member of staff working in a community team where we're asking them to do some more specialist work, and that actually when we look at their job profile, suddenly they move, say, from a band 7 to a band 8A or a band 6 to a band 7. So it could have quite a significant impact for the organisation. But as I say, we've got to do that piece of work, we've got to do that scoping piece of work. We've got to begin to understand what's the sort of the impact on the ground. The other bit for me around this is that, it's a national piece of work. Our staff know that, they recognise it, they understand this is going on. So there is an expectation there as well. So we just need to manage that as we go through this and communicate effectively. One other point just to draw out, obviously, the board has already been appraised around the strike. We are just coming out today of the sort of 5-day strike by our resident doctors. I think it's fair to say that that has gone, that's been managed and planned incredibly well, and I'm sure colleagues will update accordingly. It's also fair to say nationally there's a broader emerging picture around other disciplines potentially looking at strike action as well. There's nothing formal at the moment. The RCN has been talking of informal sort of soundings across their membership, but I think there's a sense at the moment that this could go down a particular road. So again, it's important just to let board know. And obviously you'll see in the paper that the pay award will be paid out, issued in August for all our staff at 3 and sort of 3%, etc. for Agenda for Change, and above that for doctors. I'm going to stop there because I'm conscious of time.
Jackie?
I've just got a couple of observations for Stephen. So appraisals still seem to kind of bob about, is probably a better way of putting it. And I'm just wondering whether there's an opportunity to integrate the appraisal system into some of the conversations that you were talking about earlier in terms of the leadership, because the appraisal system, although has changed, the new form is really welcomed. And we're just wondering, that's another opportunity to hear the voice of our colleagues in a very personal and appropriate way. And at the last committee, it was really welcome to start the conversations about how we start to integrate strategically some of the people agenda. And Steve Cox mentioned it earlier about how we can integrate maybe the staff survey results with the CQC results, so we have an inclusive action plan. But thank you for that, Stephen.
No, I think I fully support that actually. I mean, appraisals as of today at 91%. There's a sort of a sense building that the new framework, the new approach and the training is having a positive impact, certainly across the directorates. Where we're currently struggling is around corporate services, and in particular, some of those areas where we're doing consultations with staff when we are, so again, that's quite expected actually in the context of some of the challenges we face around corporate services. Adult specialist and children's as of today at 91, nearly 92%, which I think is really excellent. We should recognise that. But I think that's a great suggestion.
Kish, do you want to come in?
Thank you, Gish. I think it's just another point to note, Chair. The organisation's gone through a challenging couple of months with regards to some of the changes that we needed to make in terms of forecast cost improvement and some of the narrative that is being shared with the partners about their approach to cost improvement, etc. And I'm really pleased to say that I think it's been, and this is a big thank you to Chris, really, in terms of communications with our workforce. We've done this with them, not to them. I hope they would accept that. But I also appointed note, Chair, to say a significant thank you to our union representatives that have been very balanced and incredibly measured and very sophisticated, working with the management side to help the workforce get through what has been a difficult period. And the next 12 to 24 months in the NHS is going to be a difficult period. And morale is not the best it's been. And I think this organisation recognises within our workforce, it's tricky because of everything. But I guess that's across the entire NHS, but we're doing as much as we can. And I will touch on this under AOB, if I may, around our staff awards and our staff recognition schemes, because that's a really big part of this moving forward. But if we get time, if not, then I can brief separately.
Just building on what Steve just said there, there is a tactical risk arising for the organisation, okay, for 26, 27. Industrial action has taken place. There's the risk of further industrial action. There is action taking place about reprofile changes. Within all of that, there is a history and a statement that there will be no further resources. It is clear that the transformation of the workforce for 26, 27 is a tactical risk that we should start addressing now.
Yeah.
Might be worth considering which committees that risk mitigation cost.
Thank you for that. Now, as a point of process, do we want to actually raise that as an action to capture that?
Should.
I think we should.
Yeah. And I think it's split between, well, there's and there's the whole P and C and B and P, but also there'll be quality. And if you align it to the conversation we're having earlier on service reviews and all of that piece of work, that actually, by its very nature, transformation of our clinical pathways and our sort of delivery mechanisms is going to fall out of that. And I think it is something that we do need to sort of look at soon, given, 26, 27 is not far away.
Yeah. And the word planning, get the terminologies right, also needs to be factored in as well. Point for me, I think if Kathy was here, big thank you for her for the work she's done in terms of the industrial action, and big thank you to all our staff who have been in and stepped up to the plate in terms of making it as least impactful as possible. Committed to do.
And Chair, I was going to raise that under the medical director's report, because Kathy's and the team, the medical directors, have written point on this with support for medical staffing and significant support from EPRR. The approach of using the EPRR processes has worked incredibly well. So we manage that through business continuity, through the highlight and escalation of risk. We check on a routine basis in terms of any hotspots, and then they're in routine dialogue with our partners for mutual aid. And I joined a lot of those calls, so thank you to directors that were on call over the weekend. I joined those calls with my director colleagues, and it's really nice to see the team working as a team. It was superb. They do it anyway, but it was really nice to see it. And I think a significant thank you. And we will write to those staff to say thank you, Chair, from the board. But again, I think a big thank you to, and this is not a reference point to the industrial action, it's any member of staff that made personal sacrifices to lean in to protect our patients during this period. They respected their colleagues' choices, which is fine and right and proper, but they also made sure that they prioritise patient care. So I think a big thank you. And we will, Chris, we'll make sure that we send that out to our workforce. Thank you.
Okay, thank you very much. Okay, move on. I did see Sharon on call. Sharon, over to you. Welcome.
Thank you. Welcome. Thank you. Thank you, Chair. Thanks for letting me present 2 ED&I items today. So we've got firstly the ED&I annual report and then the 3-year ED&I strategy, and I'll take them both as read. Thank you. And hope they were quite colourful for you, so not so text heavy for you to read. So firstly, the ED&I annual report, I'm presenting really for assurance. The report highlights our ED&I work over the past year. So in terms of progress, commitment to staff networks, lived experience and our engagement with our staff. The report ensures also we've met with all of our compliance. There's a lot of compliance and that's significantly gone up over the last few years. So our compliance, our statutory and our mandatory and regulatory requirements, they've significantly increased. So just a few highlights I would like to point out for you. Really proud of the team and the work around Ninja Theory. So working with our Cambridge gaming company that's been an award-winning, BAFTA-winning, award-winning game, and the mental health support they've put in there and lived experience. Peer training into Whitemoor Prison. We've never done that before and was just phenomenal. We were blown away with that. A new staff network, so the Armed Forces staff network started this year with Tom being around. Reverse mentoring with the ICB and the voluntary sector was really positive. That's the first time we've done that wider with the ICB. And also it took a mammoth amount of time to co-produce our ED&I strategy, which you'll see in a little while. So that's just a little bit of some of the things I wanted you to kind of focus on today in the annual report. So are there any questions relating to that part?
No.
Okay. Hard to hear. Nothing, carry on.
Yeah, carry on, please, Sharon.
Lovely, thanks. Thank you, Chair. So the next one is the 3-year ED&I strategy that I'm hoping to get us as a board to ratify and then publish. I'd like to get it on our website. So this has been quite a mammoth task over the past 6 months. I would say we've tried really hard to co-produce this strategy. We have taken it to numerous operational meetings, clinical meetings. We've taken it to all staff networks. We've gone to trust sub-boards. And we've taken on the feedback, I think, from almost every point that we could make. We've had discussions with NEDs too, and we've taken on that feedback around the layout, the vision, the presentation, how it looks, the colour, etc., etc. So to try and make it really attractive. In summary, we've developed 4 overarching ED&I themes, and even last week we just changed them round because one of our colleagues said actually culture should be at the forefront of that. So we changed it so it reads culture, people, engagement and reporting, and they all aim to support our strategic goals. I think our plans you'll see from the strategy really align with the CQC feedback, and that we need to see a focus on, I think, on the following areas that I'm really keen that we as a trust focus on. So that's been more data driven. I think our processes and our RES and DES are still very manualized, and I think we need some real good support to help us make that better. Reducing health inequalities and links to health equity and clinical strategies and PCREF. Recovery and lived experience. Developing more development of an inclusive workforce and ensuring career development, and improving the experience for our disabled and global majority colleagues, reducing bullying and harassment and discrimination that is apparent in all public sectors, but it is apparent sadly in the NHS, and obviously improving their experience. So that's the areas that we really wanted to focus on this year. So hope you've had a chance to have a look, and I wonder if there's any questions on that. it's a 3-year one going forward, where the last one was a 5-year one, because I think we noted that there'd been significant worldwide, national changes over the previous 5 years. We'd had COVID, Black Lives Matter, all of those things. We've had wars, and I think we really wanted to take stock and think how quickly the world can change. So we reduced it to 3 years. So any questions on that?
Yeah, Sharon, hello, it's Mike Napton here. Thank you very much.
Hello, Mike.
Hello. It's more a bit of a formative moment for me. Is it, how shall I put it? In my head, I've got two bits of EDI with regards to staff. And then you've got equality and diversity as regards to our service users.
Hugely, yeah.
Included in this. They are both included, I think, in this 3-year strategy.
They are, yeah.
Suppose I'm asking, is that okay? I mean, is that going to work? Because they are different issues, and yet they're both equally important. They're going to be monitored in different ways. So, I guess what I'm trying to get my head around, the question I'm landing is how is that going to be managed? Really?
Okay. So I think brilliant question, Mike. Thank you. I think we've acknowledged that over the last few years we've been very staff focused. So a lot of it is around our workforce, our people, addressing issues there. But actually, the patient focus, being patient centric, has been less so. Of course, we will support any patients on wards, etc., that need our support, and we do that. And we're very thoughtful around what those areas and environments look like. However, I think it's really timely with the work that Mike is supporting in terms of the culture of care and how around anti-racism and all of the work that I lead with the anti-racism working group. I think it's really timely on our wards that we focus on everything that we can around ward environments and our patient-centric focused ED&I. In addition to, it will be hard, but it isn't just my team that's got to do that. It's all of us have to do that. So I think it's long overdue, Mike, I think.
Yes. So it doesn't all fall to you, Sharon.
I hope not, because I haven't got those bigger shoulders. I really can't do it.
Patient and care involvement, patient and care engagement, hearing the patient's voice, mental health community survey, there's all other stuff. So I'm just, I guess, trying to get it in my head, filing this away in my brain so I understand the issues.
Do I want to come, or should we go to Cathy?
I'll go at the end. Let Catherine say.
Be very brief. It's just to add that patient and carer EDI issues are absolutely central to the clinical strategy, and so they really are core to that work.
Thank you, Chair. Oh, Jackie,
I just had one very quick question. It was very similar to Mike. Sharon, just looking through the report, you've got over 30 actions, which is very ambitious, and it's a great strategy. Do you see any risk around those actions actually being achieved, and how are you going to sort of air traffic control all of those actions?
I like that, air traffic control. I like that. So I think ED&I, if I'm honest, has always been a risk. It's been on the risk register for a long time, and that's in terms of resource. So it's really hard to keep a focus. I'm trying really hard with my team. We've got an operating plan in the background that we look at every couple of weeks. We make sure that we link in. So we link into other teams in corporate. We're linked to, heart and soul. We're linked to people. We're linked to recruitment. So it's about how we try and engage and not duplicate. It's about doing, the joined up work. So working hand in hand with our other colleagues. But you're absolutely right. It is ambitious. And I think it's something that we're really keen that we stride on with, because we've got so much more that we need to be doing, Jackie.
Thank you. And Sharon, thanks for both of these documents. I've just checked my watch. My watch isn't working to my phone. I've just checked my phone. It's not 12 o'clock, so I can't be contentious because it's not past the watershed, but I'm going to take Chief Exec's privilege and do it anyway. And that is that reports like this and strategies like this, when you ask yourself a question, how do I know whether this is going to be a success? It's when you don't need this strategy. And so the question that we need to be asking ourselves is, how do we make sure that all of these things are business as usual? That we have a voice of conscience, we don't have a work program. We have an ability to look into our organisation to make sure it's fully inclusive, no one's disadvantaged. And therefore, I think what we need to be able to work towards from an air traffic control perspective, I love that, I'm going to steal that with pride, Jack, is that actually this should be deploying a culture of an organisation that doesn't need to reflect on this because it just does it. And many organisations will really struggle with this. But I think the features that are included in this strategy are really good. They're really solid. But there are steps, aren't there, Sharon, that we've taken to try and expand on this. So our partnership with the Race Equality Commission around anti-racism, some of the work that we're about to embark on with the Positive Practice in Mental Health team, to try and get under the bonnet of the organisation, to understand what is getting in the way of people recognising, celebrating diversity and really embracing that. The evidence that Catherine talks about is very stark, because there are some groups of people that are more likely to be brought into our services. There are some groups of people that are more likely to find themselves in a police cell or in a place of safety. And we need to unpack all of that to understand why is that the case. That's going to be a lifelong journey for all of us as we get into this. But I think, Sharon, the point of note here for me is this needs to be our absolute routine cause and business as usual. We want to be a diverse organisation no matter where you are and how you work, and then be celebrated for it and respected for it. So I just want to say thank you for putting that together.
Lovely. Thank you. Thanks, Steve.
Any more? No, I think then thank you very much, Sharon, and good luck with your air traffic controlling.
Thanks, Chair. Thank you. Bye-bye.
Thank you.
That.
Yes, we are. Yeah. Thank you for that.
And Chair, can I make a plug for reverse mentoring, please, on the basis of making sure the organisation celebrates that and embraces it? And Sharon, you would be delighted to know I got my bronze badge the other day.
I did hear about that.
Not as gold as Mr. Walker has got, but I'm on my journey. So not setting too much of an example around the table, but we need to start wearing those badges with pride.
Lovely. Thank you. Thanks for the plug.
Thank you for that prompt, Steve. Yeah, so as a board, we're ratifying the strategy.
Thank you.
Off the annual report.
Yeah.
Okay, thank you. Next. Board development, back to you.
Thank you, Chair. So this was going to be a double act with myself and the Chair. So, Chair, this is going to be a double act between you and I. I think I'll take the report as read, but with a couple of focus points. So again, reflecting back on perhaps questions based around our CQC report and questions we've asked ourselves on the CQC report is, do we have the necessary development programs in place across all of our teams, not just the board, but all of our teams? And when you take that moment to do a stock take and evaluate that, there's always opportunities to improve. This paper reflects what that improvement looks like. So the proposal to come forward to this board is, and again, significant thank you to Nicky Brooks-Smith, who's coordinated a lot of this, is that we are looking to use this process to strengthen our governance, improve leadership and our oversight, unpack some of the narratives. So I use the word visibility as a really good example. What does visibility mean? So does visibility mean to a member of staff they've seen you? Or does visibility mean that they've talked to you, you've heard, and then you've acted? There's a big challenge for us. So when you start looking at those words, unpacking that in that very big word called leadership, support our strategic decision making and therefore liberate and speed up our governance mechanisms to make sure it's safe, but it's not clunky. It allows clinicians to raise concerns, raise issues, raise decisions, investment cases, without it going around the block maybe more than once, in order for us to do that with speed and enhance our board effectiveness, which will be an annual cycle of reports anyway. So as part of our code of governance, under section 3, the areas there are 4 key areas for the board to focus on. We do have an external partner that will come in to support us with that. And for non-exec assurance, we are also going to extend this into our working groups, our directorates and our executive teams and leadership teams, because I think we would benefit all from doing these refreshes. So the report is here for recommendations to note and endorse the approach, and we will use our board development time using these methodologies with a partner to come in to give us some of that core training and challenges.
Thank you. Any observations from the board? It's yeah, very. Yes.
Brace yourself.
We're in for a ride.
Yeah.
Okay, I'm not seeing anything from anybody. Thank you. So note and endorse the proposals here in terms of our development. Thank you. In it, but I think it's you then, because it's left. Steve, please.
Okay, thanks, Chair. The report from the Business and Performance Committee, I'll take it as read, mindful of time as well. We've covered some of the points in the report, and there are a couple of items on the agenda that will update some OPR and finance, for example. But the key points that came out of our last meeting last month, the operational risk report was considered. We've got in there now an infographic which shows the trend on risk, trajectory of risk over time, which was really helpful to see. There were no new risks to note, but a couple of to flag. Windows 10 upgrade to Windows 11 was the score was reduced because capital allocation had been applied to it. There is still some more work to do on that to implement it by October. So we'll be keeping close track of that over the next couple of months. Cyber security remains one of the higher risks for us. And we'll receive an update after the system outage exercise, which I think is planned for the autumn as well. Again, really important. On the APR, we've got that on the agenda shortly. I'm going to flag the out of area payments, the detailed plan that we spoke about earlier coming into the August meeting. I'm sure Holly will pick that up shortly. Finance, it was the month 2 finance update that we saw. I think there'll be a further update shortly. Probably the big item that we're keeping a very close track of is the financial efficiency programme that we're looking at and considered at the meeting last month. The target of 17.6 million to be achieved through this financial year. Some good progress in terms of the process that's in place to see the plans, the project plans that we need to see. We gave that item a reasonable assurance in terms of process, but partial in terms of likely outcomes. We've still more work to do, I think, to pin down those and deliver the savings that are needed to achieve the financial efficiency programme. A couple of other points. We had a report back on the digital transformation board update. Some really good progress with that in terms of its leadership and the preparation of the digital strategy. I think noting that like a number of strategies, it needs to be able to reflect, respond and help deliver the clinical strategy as that comes through over the autumn. Capital and Infrastructure Committee update, we gave partial assurance to that based on the first couple of months of capital spend that we received an update on, which was underspending. Looking at the papers today, that may have been rectified, but we'll come to that no doubt a bit later. And then the final point, which we've touched on already, we've seen an update on the clinical and the overall trust strategy updates and the important connectivity between the two. And that we're expecting the clinical strategy, particularly go to Q&S in the autumn as well. So I think, Chair, that's what I wanted to highlight.
Thank you for that. Nothing else? Do you want to come in?
Thank you, Steve. I think this is really again a point to yourself and Steve, and it's a thank you really in terms of both supporting the strengthening of the business and development team in terms of looking at our contracting, but also wouldn't be appropriate here, Chair, to talk about the landing of several new contracts within the organisation. But I am delighted to say that they're being done from a I say the word commercial, but what I mean by commercial is from a safe business perspective to make sure that they have long range planning within them. And again, from a strategic perspective, I'm really pleased to see that those services that we have been awarded are all to do with being able to increase the offer that we can give locally, as well as some of the stuff a little bit further afield. So Mr. Legood and I are talking about revamp of some of the way in which we're presenting that, see through business and performance, in terms of both a commercial outline and a market scan, in terms of some of the growth and the business opportunities that may come our way, all against the backdrop of needing to improve and support the delivery of our clinical strategy. So not business for business sake. It's really important to say that, I think.
Okay. Then Holly, I think you're next.
Indeed. Thank you. And a few things that I'd like to bring out of the paper. The first is regarding ADHD. So the board will recognise that we've had an ever increasing waiting list with some very long waiting times, and we've been doing quite a lot of engagement over the last 12 months with the ICB. We're now in a position where we will be prioritising those patients that require the specific specialist care that CPFT can provide. And the ICB have commissioned some alternative choice providers. So we will be able to see some much welcomed movement on our waiting lists. We're just working through the sort of common strategy in terms of both with those choice providers, but also with the people that are on our waiting list currently. But I think that's a positive step forward, and we will look to implement that as quickly as we can. I know we've talked about out of area placements. I am going to mention them again just because they are really key from both the quality and safety perspective, but also supporting our financial position. So the board will note that we continue to be stable, so roughly between 5 and 7 patients remain out of area at any one time. But I do want to give assurance that we are, whilst we badge them appropriate, we are aware of the impact that sending those patients out has. So we are looking at how we might consider being able to look after those patients within our own bed stock going forward, and having those conversations with the ICB. Inappropriate, the board will see that that's continued to decrease overall, but there are fluctuations. Adults and older people directorate continue to work together, so we're now looking at how we might look at some of our bed stock more flexibly in terms of that acute population, but also thinking about how we can sort of share resource and learning across patient flow. And at BMP and QNS, we will be bringing the plan that actually talks about a new service delivery model that has been clinically led and discussed with our patients. And we're quite excited about that and look forward to sharing that. I want to continue the sort of good news story that Steve started in terms of, I really want to highlight the clozapine initiation work in the north using virtual ward. So we've now seen 4 patients go successfully through that programme. We are the first mental health trust in the country to do this through a virtual ward. And it means that actually patients that, again, we were not able to start on clozapine are now being able to be started on that treatment. And we're looking to see how we can increase numbers for clozapine, but also looking at how we might think about other patient pathways that might be suitable for virtual ward. But again, really good example of integrated working between MWAFT and ourselves. And huge thanks to the team who, when they first floated this idea, were met with a little bit of a, mental health patients in a virtual ward. And I think we've really sort of successfully said it can be done. So huge thanks to that. I do want to flag Wellney Ward. So Wellney Ward is one of our inpatient rehab wards, and you will see that the GPs that were supporting that work, that ward have withdrawn We've put in place temporary support measures, which I'm going to acknowledge has been challenging. But what we are doing is looking at the medical cover across all 4 of our inpatient wards as a matter of urgency to ensure sort of consistent and sustainable support. And then it wouldn't be an operational performance report without mentioning waiting lists. So mental health, you will see that in adults, our mental health waiting lists have seen a slight increase. Across children's and OPAC, a slight decrease. Physical health, our waiting lists have increased across both children and OPAC. And in our children's neurodevelopmental service, we're seeing an increase. We're looking forward to doing the service reviews, because I think this will help us highlight the increased demand, the increased acuity, but no additional resource. So the clinical teams are looking forward to being able to share that. We are always looking at pathways to understand sort of what changes we can make to try and make pathways more efficient and more effective. And I do just want to highlight that people see that the learning disability pathway has shown an increase. And I know that will be a concern because of the dissolution of the learning disability pathway. That is a data cleansing issue. So because of the dissolution, we've currently got data that hasn't fully migrated across. So we're doing a data cleanse so that we can be really clear what that position is.
Thank you, Polly. Although Steve got something.
Thank you, Holly. I had a question on the integrated performance report, reviewing the KPIs. And it was just the timing of that and the sequencing. So if we're looking at the trust strategy and the clinics, will the KPIs reflect what we're trying to achieve in those strategies? Yes, I'm sure.
The answer is yes, and people will recognise this. It sounds really simple to sort of pull together all our KPIs so that we're reporting consistently, but also able to triangulate. So if we think about sort of Stephen and Rachel's reports, we're all presenting it in a slightly different format. So actually, if you're looking at, so really trying to sort of bring, I suppose, some discipline to how we're reporting. It's really complex because people feel quite passionately about KPIs. We've also done an engagement piece with our directorates, because actually we need to make sure that what we're trying to measure is important to our clinicians and important to our patients. So we're looking much more at outcome data, which you'll see probably hasn't been potentially where we've reported previously. It's been about sort of numbers rather than sort of actually, are we seeing the numbers and getting good outcomes? And we will absolutely be aligning it to both the trust strategy and the clinical strategy. But it is a complex piece of work.
Thank you. Mike,
2 quick points. I think I'm right in saying that we're going to be required to say something about length of stay as well as waiting lists as part of our reporting, which will be helpful. Yes. Say something about that. And then the other was last time I was interested in internal care variation in terms of the access to care, which I've spoken to Steve Cox as something that might be helpful in terms of maximising the use of our resources and efficiency. And but at the moment, I don't have sight of that data. There's a comment on that, or not maybe not now, but.
Yeah, so I think, and again, that probably it really nicely links through to the sort of EDI work in terms of PCREF and that patient and carer, because that's an element that we're looking for in terms of how easy does our local population find accessing our services. So I think that we can probably pick that reporting up through our PCREF data reporting. I've forgotten your first question.
Length of stay.
Length of stay, you're absolutely right. So length of stay will be a reportable metric. So we will be building that into our operational dashboard, but it is also forming part of the sort of remodelling inpatient care across our acute adult and older.
Okay,
Thank you.
just on that, correct you've mentioned, but are you asking about the internal care variation once they are in service?
Yes, it's more than just race equality. It's about access to and utilisation of our services in general. And we'll be interested in the conversation about that. And the key question is what's the data you need in order to get insights into that? So that will be helpful.
Okay. There you go.
Thank you. I was just going to pick on the ADHD point about ADHD. There's obviously a huge waiting list there, isn't it? And I'm fairly quite ignorant of the service. I'm not quite sure whether it's more about assessment or then about other problems or more about treatment. But I gather that in our children's services, we've been using some technological approaches to speed up ADHD diagnosis for about 10 years now, which is terrific. And these are not licensed in adults yet. And we're also looking at things like ambient technology to try to speed this up. But do you think we're sufficiently in touch with the research side of this, wherever it's cutting edge action, to try and get these new innovations, if they come as early as possible, into our services?
Yes, I do, and we have been looking at a tool that to support triage. The difficulty is it isn't actually approved yet nationally, and I think you always need to be a little bit careful, particularly when we've got a very large waiting list, as we have. But Alex, who's the lead clinician, is part of the national group looking at ADHD and the pathways, and she's been a huge part of the work with the ICB and providing her expertise and sort of information that she gleans from that national body.
Kish?
I think nationally we've gone from mooting discussion around what is the correct performance standard to that now coming on the horizon, okay, to being implemented. I think there's a question for us, which is what is the right performance standard that we're aiming at for our local population? Whatever that is, I think it's worth getting on the agenda because it will drive quite considerable numbers of discussions about headcount, money, efficacy. I think that there is a discussion that moved from being mooted to now being put on the table. We need to get an answer.
Yeah. Thank you. Just from me, one point, innovation. I love innovation, and in terms of the closet, I'd like to say is I'm glad they've been brave to step into a very, very limited space, and it has paid off.
Yeah,
that is good to see. In terms of the team there.
Chair, if I may just take the opportunity for if people are listening in and are not familiar with the treatment pathway for clozapine for patients that require that level of support, I would recommend that you do look that up because these are communities of individuals that do require quite a significant amount of support. And so the bravery that you talk about there, Karen, is twofold really, because these are complex pathways. And often people in quite rural areas that find it difficult to come in for physical observations, this ability to use the virtual ward means both the treatment and the efficacy of the treatment is fantastic, but it also saves a huge amount of disruption to the patient's life, which means that their continuation of their support on clozapine can be extended. Whereas we do know that this particular group of people, the drop-off rate for this pathway is quite high. So it is something for colleagues, if you're not familiar with that pathway, as governors, we can pick that up through our quality safety. For those of you members of the public, maybe something worth reviewing because it's a really quite significant piece of work this is.
I'm just going to end on a really shameless plug because I feel Steve gave me a nice in. In terms of the team, the CPFT team who have started the clozapine service are doing some fundraising through our head to toe because one of the barriers to the virtual ward is digital poverty. Yeah. So people need access to data to have the right physical health checks to enable them to have the clozapine initiated. So actually they're doing a fundraising run to collect money to try and provide SIMs for people who otherwise perhaps wouldn't be eligible for our virtual ward. That obviously is a conversation we're having with ICB colleagues in terms of how do we ensure equity. But in the meantime, I really want to flag just how passionately the team feel about making sure that everyone can have access to that service.
Thank you. Okay, Kish, you're on.
You have in front of you the monthly results, so the Q1 results. I suppose overall, they're not untypical of the NHS as a whole. We are on plan at month 3, so Q1. Back for about 50,000. Forecast at the moment is still break even. The key external variance, so as opposed to the internal stuff that Steve highlighted in the report earlier, is the strikes. So there is just no understanding at the moment about what the scale of that impact will be or its longevity. So all comments about the position are subject to that as being an unknown at the moment. Within the I&E position, despite it being a break-even overall, it's not quite got there the way that we planned. So while, for example, the cost improvement programme overall is about on track, it's not there because of recurring measures that we planned. It's there because of non-recurring items that were unplanned. The implications of that, if they do not turn out to be recurring, i.e. if it turns out that it's not a delay, but a true stop of the programme, thing that we're not going to do as opposed to it's just taking longer than we expected. If that 26, 27 will become immensely different. So it is quite important that we do actually still implement it, even if there are non-recurring measures in place at the moment. That's one. Then the other thing that's coming across from I&E, from trying to have a look at the numbers now, is in many ways, the organisation's financial issues are not widespread. They are isolated to a few areas. So a resolution of them perhaps should be targeted. So specifically, if you look at the finance report, actually within the 3 clinical areas, 2 of them are not a problem at all. Being direct, I'd say the issue with decision making to actually implement what is already there, not the fact that they're not managing the money. I think there is something probably to reflect that are not widespread in the organisation, they are confined. The second thing I probably should highlight from the report that Steve said earlier on was capital. So capital is showing that it is broadly on track now as at month 3. But the reason it's showing that it's on track at month 3 is because people profile their plans. So that instead of being in 12s, they're now as they would see being implemented. The organisational issues have always centred on implementation. So if that risk has not gone away, it's just being implemented in the last quarter now, explicitly up front. So more monitoring of the actions can take place as opposed to waiting for the actions to result in an adverse outcome. And we'll note in the private board later on, there are some business cases, 3 of the biggest business cases actually, that need to get approved so that changes can, or the spending can start to occur. But it remains an issue that actually the risk itself has not changed, it's that you get a sight. In terms of cash, the organisation remains in a positive position. But the thing I probably need to highlight is, despite that positive position, it should be more positive than it currently is. So we are owed money by 2 organisations, one NHS, which has been 1/3 resolved, and 2/3 seems to be a dispute about 100,000. Probably need to get involved to settle. So I'm less concerned about the NHS dispute, which is about on the monthly papers, it's showing $1.5 million. Okay, half of that's already been paid as I sit here now. The other $1 million is where we've got £100,000 dispute that I need to have a look at. The other one is CCC. Okay, so Cambridge Community Council, which owes 5.9 million for services already delivered relating to 24-25. As of 2 days ago, we appear now to have satisfied all their administrative checks, okay, and they have given us the order number, okay, and the invoice went out yesterday. So I'm hoping that we will now get paid in the next 28 days. If not, I think there is going to be a need to be formalised because it's been going on 15 months now.
Okay, can I just ask a question about that? It's Cambridge, this is Cambridgeshire County Council. So we obviously, our lists are showing that they owe £7.7 million at the end of the month, at the end of the quarter. And you said the invoice has gone out in the last couple of days. Was this uninvoiced income then, or was this accrued income, or was this a fixed to an invoice?
No. So the history of this was that there was an invoice that went out for the fine. So it's 2 lots of money that make the amounts that you're showing there. I am only talking about 5.9. The other one is within this year. It's
right.
For the same service, but it's within this year. The 5.9 was originally billed to them. Okay, because they were in dispute with the ICB for this service, which relates to the cabal, the order number against which that invoice was raised was not valid. There's then been going around the houses about the order numbers, which have finally been got 2 days ago from personal conversations that we've had. So the invoice had to be reissued.
Right.
So that's why I say, I make the statement actually explicitly, which is it's an administrative runaround.
Right.
I think it's also worth saying that, you know, conscious that this is a public board and therefore I also want to express a thank you to the authority for moving this forward. And I think it's really important that they recognise the fact that there's been some stubborn areas of disagreement that I think seem to look like they've got to a resolution. If there are any additional areas of resolution that are needed, I can pick that directly up with the Chief Exec. But I think a thank you really to CCC for moving this forward with us as a trust. I think the NHS partner that we're talking about, Kish, is also in the same headspace. So again, a thank you. They're still unresolved issues and they're stubborn. But as often with the case with this, there should be finding a way through the resolution, which I think we're at. But there is a risk of escalation should we not get
that. That's it.
Any more observations? No. Okay, thank you. It's a toe charity, which I think is you.
Thanks, Karen. I'll be super quick and just highlight the 3 main points on the report. One is we have a new branding, which was successfully approved by the trustees for the charity last month. Also, that brand has now been launched through the support of Chris Walker and Hannah. There was a degree of confidence in the terms of income that the charity is receiving this year. And also we've discussed at the committee about a strategic refresh, which we're going to do a roadmap on a timeline for this to be presented to the Board of Trustees in January of next year. And just for this board to note that the charity wants to make sure that it continues to connect to not only our staff, but its patients. And Hannah has asked the committee to work with a forum of staff to constantly loop back around to make sure that the charity is delivering for the staff and the patients and the people that we serve and that they stay connected. There might be an opportunity to do some double work in there with some of the forums that Steve mentioned, but without conflating 2 issues. But that's it.
Thank you. I'm conscious of time and let's squeeze the last few items, but Chris, you want to come in?
Yeah, just very quickly, a shameless plug for Head to Toes Big Bike Ride, taking place on Sunday, the 10th of August. If you do wish to get involved, you can do. I know Steve will be at the start line, so just wanted a shameless plug for that.
Okay, thank you. Brian, and then I think Stephen.
So just so I'll pick up on the audits committee report. So we've met twice since the last meeting of this board, and we've really discharged I think 2 of the main things that we look at. One of them is that the annual report was approved and recommended for filing with the NHS. And Chris and his team put that together with a lot of help from many people across the organisation.
And I think that read very well this year. And also then we signed off the draft accounts for the year for 2025 with a clean audit opinion. The auditors had a clean audit opinion, which again is always reassuring. We should never take for granted, but I think it's fair to say was expected. I think there are a number of accounting issues which are referred to in the paper, but the most interesting one, potentially the most complex one, is around the PFI model, which is really how we account for the PFI around the Cavell. And what we've agreed as a change in the process with the auditors is that we look at that a couple of times a year, so it doesn't become a year-end issue, and then that makes the year-end audit process much more efficient. And I think that's a very positive development, because it's something that has come back a couple of times over the last few years. A couple of concerns around financial sustainability, which the auditors need to look at, and clearly the biggest of those is really just around the cost improvement. And we've already referred to that and the consequences of that for this particular financial year. So that was so, and the accounts and everything was filed on time, which is good news. We had a second meeting then, which is the more technical audit committee meeting, where we included internal audit reviews and so on. I think the report, there were a higher than average number of actions outstanding, but we pushed those back out to the teams, and we're expecting that those will be, it'll be a much smaller list come the next meeting. I think there's a recognition that enough effort wasn't being put in some places, but that's been embraced across the other parts of the across the other parts of the organisation and the other committees. One word that I do like to see every year is the head of clinical effectiveness reports. So Louise Walker came in and presented that, and it's one of the most positive reports we see, that 99% return rate on baseline assessments in very good shape, and it's always reassuring to see that, and that goes back to probably the committee too. So I think that's great news, and always reassuring to see. And I think those were the only matters worth responding to or referring to at this point. Questions?
Okay, thank you, Brian. I will go to Stephen, Cambridge Hospital.
Thank you, Chair. So there's an update on the progress with the Children's Hospital project. The CPFT committee has met since this board last met, and we have another meeting next week, so there'll be further updates after that. The headlines, like I won't go through the entire report. The full business case work now is progressing. The date of submission will be informed by the contractor that on board shortly. Likely to be spring summer 26. There's several strands of work going on to that to come forward in that timeline. The priorities for the rest of this calendar year are set out in the paper. I won't go through them all, but one important one for us to be aware of is the joint venture for the design, build and operation of the hospital. It's something we're looking at the business case for very carefully. We've had a session with a few members of the board with the project team to look at that in more detail. And we'll have further discussions next week and ahead of bringing the joint venture business case to the board in the end of October, which will be an important decision point in that process. Just want to flag the Front Runners programme, which I think is really exciting part of illustrating the stronger collaboration that there can be, will be through the building of the hospital, to bring that forward, to see that collaboration and in itself can help to shape the design and the culture and the care model within the hospital itself. And there's some detail in the paper about that. Other than that, Chair, I think that's all I wanted to say. The board decisions look forward are in the paper. As I mentioned, the joint venture business case in October will come to the board, and the full business case May, June 2026.
Thank you. Good afternoon.
Can I just check one thing that an email flagged as trust chair? Do you think there's enough time between the joint venture coming here and having to go to NHS England? Because I gather that's quite tight.
Yeah, I think it's definitely part of the decision-making process that it has to be signed off by this board before it goes to NHSE. So we have it on the agenda for the 29th of October, this board, and we'll see it at the CCH committee we have prior to that. I think Rudolph's point is spot on. I think for your assurance, so Rudolph, it goes through the committee for a decision, and there's a lot of debate in between. So I think when it gets there, most of the irons should have been used to work out any creases, would be my expectation and hope. And it's safe to say that Chris, you and I attended an event yesterday with the developers that have been identified successfully, joined by some of our parents and service users and young people, and the developers themselves, in partnership with both the university, CUH, ourselves as a trust. It was really good to do that, celebrate the fact that they've been appointed, so the movement is starting to happen. That's the first case, Steve, that we've seen signed off for the appointments of the developer. I was most assured yesterday. I met one of the clinicians who had been recruited as a nurse to manage this process from a clinical point of view, who works between this organisation and our acute partner. I've never met anybody so passionate in my entire life. And one of the things that was a remarkable gift that she's got is to help design and build something that you'll be able to walk in and care in. And some of the input that she was able to make, she knew more about the build, the development, the groundwork and everything else to some of those developers. And I think if it's appropriate at the right point in time, we should ask her to come and talk to this board, because she gave a real account of how important a true integrated care offer was. She also talked about sometimes the distance between acute and physical services, community services and mental health. And as a nurse of many years, I won't give away her age, she recognised the fact that actually none of that is independent and separate. She was fantastic. So I think I'd recommend asking her to come here to talk to you about the clinical assurance side of things.
Thank you. Any more? Steve, you okay with that? Okay, then.
Thank you. I'll take the report as read, the Chief Medical Officer's report, which I'm presenting on behalf of Kathy. Just 3 areas to highlight. I know we have already referenced the industrial action, but the resident doctor's industrial action has completed. I just want to add thanks on behalf of Kathy to medical staffing, EPRR, but in particular, I'm going to name check an individual in medical staffing, Louise Thomas, who worked over and above to provide safe service provision. And I also want to make sure that we remember to thank our medical staff, consultants and SAS doctors who stepped in to provide emergency cover day and night over the industrial action. So thank you to those individuals. And there is learning from the industrial action, which we will be picking up later this week. But as colleagues have indicated, actually, service provision continues with no disruption and most importantly, safe care. Just to highlight recruitment and retention trends for our consultants, that there is a promising trend in reduction of medical agency. And as Steve has indicated, things are looking up in terms of our substantive appointments. We do have more applicants. The majority of remaining substantive vacancies are out to advert, and they're not just out to advert, they have applicants, and some of them already have offers being made. So I think the progress there, again, due to the dedication of our clinical directors and medical staff and colleagues, has been impressive. And just finally, a note on job planning. So job planning for consultant medical staff, just to highlight that we are one of a handful of mental health trusts that achieved 95% job planning for our consultant medical staff last year, and we are committed to sustaining that progress next year.
That's good to hear. Thank you. Rudolph?
Just to echo my thanks to Catherine and Louise and the team for their support for the strike cover. It was a terrifically run operation.
And Chair, in the spirit of embarrassing people, I think we should also thank one of our non-executive directors who also did a few shifts.
Well done, thank you. Nothing more for that item, then we will move on, mindful of time. Are you going to speak to this, or is the no use of the trust seal?
We haven't used it yet.
Used it. Done. The other two papers I don't intend to dwell on.
All right, thank you.
I'll go and hang them, Windsor.
David, do you want to go on mute, please? The chief fit proper person declaration and the annual declaration of interests, both gone through the appropriate government processes and signed off at remuneration committee on the 30th of May. So I'll take those papers as read and noted. And then we are questions. We had one public question. I don't know if you want to address that, Steve.
Yes, and thank you to Mr. Fulton for asking that question. Mr. Fulton,
yes, I'm happy to receive a written response, but I would like to have 90 seconds just to raise a few concerns with the board from the community in response to the latest CQC report, positive and negative feedback, which I think it's important you hear to contextualize the report. The first thing is that the deficiencies in culture cited in the report have real and significant impacts on the trust patients. In discussing issues at the trust with patients, these issues are extremely serious. They include things such as sexual safety on wards, compliance with the Mental Health Act, and transparency with CQC and regulatory investigations, and transparencies with families of deceased patients. That's an issue that we hear raised time and time again, and it's deeply concerning. As the CQC report notes, staff do not always feel comfortable raising concerns, and patients do not have confidence that concerns raised are handled appropriately. Now, just one positive thing I'd like to say, in speaking with patients, when concerns have been raised, many patients have said that they have people on the staff who have actively advocated for them. And I think, and patients have said these staff have gone above and beyond. And I think it's important to note that despite the wider cultural problems at the trust, individual members of staff are really praised by patients. And I think that's positive. In regards to the chief executive points about complaints, there is one unresolved complaint that's longstanding that relates to management involvement in patient care. I hope that the chief executive will address that complaint directly and that it can be addressed by the next board meeting. And that's all I have. I just want to say, patients want you to realize that the problems at the trust have real impacts on their lives. And I know that I appreciate the work that the board puts in. So thank you for your work today and your work over the past several months on behalf of patients. Thank you. Oh, and I'm happy to receive a written response to my question from Dr. Napton.
And Daniel, thank you for being the voice of the patient. We've definitely heard you, so thank you for coming and expressing that to us today.
Thank you.
Can I just echo that, Daniel? Sorry, no, I call you Daniel, Mr. Fulton, but if you don't mind me calling you Daniel, Daniel, okay. So Daniel, thank you, and you know that means a lot really, because we feel that too, and I think culture, the way we interact as a service, it's not just about the interaction and the interventions that we provide, it's about the environment that we foster, and we know that the outcomes of patients, recovery of people that do need our care will be improved if we improve our culture as an organisation. And that will be a lifelong journey for any organisation in the NHS. So something that the report has given us a real sense check against, which is really helpful in an odd way. But your voice and the voice of those people rooting through your good self and some of our other advocates has reinforced that. In relation to the issue of the outstanding complaint, we will check on that, and I'll ask Rachel to also lead out on that because I oversee all of those complaints with the chief nurse. I think it would be best if we manage that through our appropriate process. So we'll make sure that we do that so that our governance is correct, rather than expose any of those sensitivities of an individual through a board. So I hope you understand, Daniel. We'll do it through the right process, but I will give oversight through the chief nurse in response to that.
Absolutely, and I trust that the trust will follow that process. So thank you very much.
Okay, then I will draw the meeting to a close and thank you very much for all contributions and attendance, and look forward to seeing governors the appropriate meetings in due course.
Thank you all.
You all.